introduce our colleague, Professor Mohamed Gamal. Dr. Mohamed Gamal will talk about a very interesting topic, which is syphilitic uveitis. Please, Dr. Mohamed.
صباح الخير. بشكر اساتذتي اللجنه المنظمه على دعوتي للمشاركه في هذا المؤتمر المميز ان شاء الله. هنتكلم النهارده على emerging cause of uveitis بدأنا نشوفه. الحقيقه انا يعني هعرض الموضوع في صوره كيس جات لي عشان يعني يبقى الموضوع مشوق اكتر. 26-year-old male was referred to me by the rheumatology committee of the health insurance for evaluation. The patient was already diagnosed as a case of Behçet's disease and has been treated by Humira for the past 6 months. The patient works as a driver, not married, with no special habits of medical relevance, smoking, alcohol consumption. The story of the patient began 9 months ago by insidious onset of blurry vision with floaters. This was preceded by skin rash and genital ulcers, and later he developed some sources of aphthous oral ulceration. The patient was referred by his ophthalmologists to the rheumatologists and was started on oral steroids and referred to the health insurance to start him on biologics. The patient showed mild initial improvement with frequent relapse of his complaints whenever he tapers the steroid below 30 milligrams per day. On examination, vision was 460 OD and 660 OS. AC showed trace AC cells, clear lens, normal IOP. Vitreous showed dense haze, more in the right eye, 3+ haze. No definite lesion could be seen through the vitreous haze, only slightly hyperemic discs. Fluorescein angiography showed late disc hyperfluorescence, but no evidence of retinal vasculitis. I tried to obtain the fundus autofluorescence, but it couldn't be obtained due to media haze. So this is the picture of the right eye, 3+ dense vitreous haze. Left eye shows only 2+ dense vitreous haze. Interestingly, I could obtain an OCT, and this was the breakthrough that helped me to reach the diagnosis. As we can see, there is total loss of the outer retinal laminations. No ellipsoid zone or IOS-OS junction, completely lost, with mild hyperreflective foci at the level of the outer retina with some sort of pachychoroid. It's more evident on the left eye, those small hyperreflective dots, along with loss of the outer retinal laminations. So I now realized that I'm not facing a case of Behçet's disease. No retinal vasculitis, and there is mainly a problem at the level of the outer retina. So I tried to think what could be the cause of loss of these outer retinal layers. Outer retinitis could maybe syphilis, maybe azure, but with azure there is no such dense vitritis. Maybe some other causes like cancer-associated retinopathy or toxic, but there is no vitritis also in those conditions. And masquerade like lymphoma, but lymphoma has more coarse deposits of the outer retina. So I thought this may be syphilitic outer retinitis. I reviewed his initial workup, and interestingly, they didn't order syphilis serology for him. I asked the patient to do a syphilis serology. More interestingly, the patient, when he reached the lab and asked them what is this test, they told him this is a syphilis serology. He called me and confessed he has multiple sexual partners and told me he would ask the lab to test him also for HIV. Interestingly, both came back positive, HIV positive and syphilis positive. I referred the patient to the local fever hospital. They started him on parenteral penicillin, stopped Humira, and also offered HIV antiviral therapy. This is the picture 2 weeks after penicillin. Vitreous haze disappeared. Even the outer retinal laminations recovered on OCT. and visual acuity improved to 618 and 636. Here we can see the picture of the OCT, recovery of the outer retinal laminations, improvement of vitreous haze, with some edema developing in the left eye. This is called the Jarisch-Herxheimer reaction. It's due to antigen-antibody reaction against the dead treponemes, causing an intense local inflammation. Syphilitic uveitis is a chronic systemic infection. Syphilis is a chronic systemic sexually transmitted disease caused by the spirochete Treponema pallidum. Ophthalmic involvement can occur at any stage of the disease, and it's not only uveitis. We have keratitis, we may have neuro-ophthalmological features, but the most common ocular manifestation of syphilis is uveitis. Ocular syphilis is a masquerade condition. It can present in any picture of uveitis. Rates of syphilis has been rising since the start of this millennium. These are percentages that showed rise of incidence in the Western countries from about 1% to 6%. So there is about 6-fold increase in the incidence. And we are not an exception. We have a similar full increase. Syphilis, as I mentioned, can present in any picture of uveitis. But there are two specific forms, punctate inner retinitis and, less commonly, like our case, a placoid syphilitic outer retinitis. This is a picture of the inner retinitis. We can see here triangular infiltration in the level of the inner retina. And here is the picture of the syphilitic outer retinitis. But this patient, this is a classic picture with a placoid lesion. But we didn't see this in our patient because our patient had a strong immunity, stronger immunity. So the vitreous haze predominated. It has a characteristic appearance by fundus autofluorescence. That's why I tried to obtain it. It's a trizonal pattern, 3 zones of alternating hyper and hypo autofluorescence. This is my paper from 2016 about the ultra-wide field fundus and spectral domain OCT findings in syphilitic outer retinitis. For diagnosis of syphilis, if we have the specific form, it's easier. Like my case, I was lucky. But it's dependent on serological tests. We have 2 types, non-treponemal tests like the VDRL and treponemal tests like fluorescent treponemal antibodies. We have to order both of them. Recommended treatment consists of intravenous or intramuscular penicillin G, adjunctive therapy, topical steroids, in addition to oral steroids, which are useful to treat the Jarisch-Herxheimer reaction. Therefore, any patient with uveitis should be screened for syphilis. Take-home messages. Etiology of uveitis is diverse, includes not only autoimmune conditions, but infections and neoplasia. In practice, it's useful to exclude infectious cases first because they are treatable causes and the steroids can worsen the case. Thank you.